bit of
Yeah, there's no Wi-Fi down the flash.
review on it before it left your short-term memory. So again, this is the text component of it. Don't let the slide or the diagram kind of, you know, it looks overwhelming. Break it down into parts, okay? But try and at least organize them so that you get the fact that these pictures are essentially just talking about the valves right here. So what you've got is, again, electrical sound, you've got pressure, you've got volume, and then you've got what's happening in the valves themselves, okay? I will try and look through a few other textbooks. I want to see the ones that I have access online because whenever you scan something, it's always somewhat crooked, so it's always better to get something that I can import and see if I can find one that presents it just slightly different, whether it's the colors, whether it's the orientation as far as ending the diastolic, starting the diastolic over here, so that you get a little bit different flavor. It might help some of you put it in your long-term memory. All right, any questions? So continuing on, we have a process for the cardiac system. It's called cardiac output. The total amount of blood that leaves the ventricles every single minute. Now, when I say that, keep in mind that I'm talking about it can be the right or the left. They're the same. Because remember, this is a big giant system. So if it's a big giant system, and blood's coming in and it's getting pumped out to the lungs, and then it comes back from the lungs and it gets pumped out to the body, that if this system starts to not pump as much blood as this system does, it will back up into the lungs. It's all one big giant circuit. So whatever gets pumped out of here every minute is the same thing that gets pumped out of here every minute. They're equal. Okay? So when we talk about cardiac output, for the most part, we generally refer to the left ventricle, but it doesn't really matter because it's exactly the same in the right ventricle. Okay, and again, I'm talking about healthy people. So there are some disease processes that this does not occur. And if that doesn't occur, then the disease progresses. Now, so cardiac output is the total amount of blood that is ejected from the ventricle every minute. So yesterday we learned a term that was my end diastolic volume minus my end systolic volume, which was the amount of blood that got ejected from the ventricle with each beat, and it was called stroke volume. Okay? So, it's a very simple mathematical equation. I take the amount of blood that gets ejected with every beat, and then I take the amount of beats the heart has in a minute, which is called what? Your heart rate. It's what you take if you work in the hospital, that's what you do with your patient. You might not count it for the whole minute. If they have an irregular heart rate, you should count it for a whole minute, but it's in a minute. So stroke volume times heart rate equals cardiac output. Very, very straightforward. This is an equation you need to know. This is an equation you should be able to do on an exam without a calculator. Again, if you think you're going to need a calculator, you need to bring one. You can't use your phone. I'm going to keep saying that so it's not a surprise to anybody on the day of the exam. So for us to be able to calculate this cardiac output, we're going to want to be able to monitor the two variables. Modify the two variables. So that when my cardiac output goes down, I have the ability of changing it up. Now, we're going to talk about the stroke volume first. Okay? Now, keep in mind that when we talk about stroke volume, and I'm going to show you a diagram at the end of this, which is one of those that I think you either should reproduce yourself on a piece of paper and take with you places so that you can pull it out and look at it, and it'll kind of help just really lock it in your long-term memory, or take a picture, put it in your mirror every time you brush your teeth in the morning, and you can look at it at that point. These are all things that are going to change it. So keep in mind, my stroke volume is going to be based off of my end diastolic volume and my end systolic volume. So when we modify this, I'm either going to increase my end diastolic volume, or I'm going to do something that decreases my end systolic volume. Both of those things would cause me to have a higher stroke volume. If I have a higher stroke volume, it's going to cause me to have an increase in my cardiac output. Okay? So these are the types of things from a mathematical standpoint when we talk about understanding the principle more than getting the math correct. So like I did with the fractions, if I've got cardiac output is equal to stroke volume times heart rate, anytime we have a product equation, anything that I increase on this side increases this. Anything I decrease on this side decreases this. Now I'm not talking about a compensatory mechanism just yet. So one of the things we talked about yesterday was somebody who's an athlete and their heart rate is going to come down. Well, that would decrease their cardiac output, correct? So what happens? Their heart has the ability of increasing the stroke volume. Therefore, cardiac output stays the same. Heart rate's less, stroke volume goes up. Okay? We're not going to be talking about that. We're going to talk about specifically how each of these things affect it. And again, if you don't quite see that relationship, make the numbers easy. Stroke volume's 1, heart rate's 1. What would my cardiac output be? 1. Wonder what happens if I increase my stroke volume. What's a number bigger than 1? 2. Huh. What happens to my cardiac output? It goes up when my stroke volume goes up. Okay? What's a number less than 1? 0.5. So if my heart rate goes down, my cardiac output goes down. Again, just simple numbers. Now again, as we move through here, there will be some numbers when we get into the vascular chapter that you're going to have to be able to do. But at least here, that lets you kind of play around with the numbers and get the principle down. Now, the first thing we're going to do is we're going to go based off of 2 different physiologists, and together they have the Frank-Starling law. All right? Now, if I was to take a rubber band, okay, and I was to put part of the rubber band on his shoulder and I pulled it back about 6 inches and let it go, and then I pulled it back about 12 inches, which one's going to hurt him more? Right, because I'm storing more energy. You want to think of the ventricles as basically being like a rubber band. The more that I can stretch that heart, the bigger the contraction's going to be because it's stored energy. Okay? So remember, the heart's still contracting as a whole, but I can modify it. I can make it so it contracts harder. Okay? So anything that I can do to stretch it, and that's the Frank-Starling law. Well, the primary way of stretching the ventricle is to have more blood come back to it. So increased venous return. One of the things that we'll talk about in the vascular chapter is that at any given point, about 2/3 of our blood is located in our venous system. And remember that the venous system is going to be basically this area here. Everything that's coming back to the right atrium. So 60% of our blood volume. And remember, our blood volume is about 5 to 6 liters. By the way, those are numbers that even though they were on the last chapter with blood, you should always keep in mind because it's going to come back in this chapter, it's going to come back in the vascular chapter, it's going to come back in the renal chapter. Okay? So if I increase the amount of blood that comes back to the right atrium, then into the right ventricle, that stretches that right ventricle. Okay? And the more I stretch it, the bigger the contraction is. Again, we're talking about healthy people. Because I can do this in a critical care unit, and I can put a patient to failure and kill them. Because if their ventricle is this big, floppy, weak ventricle, and it can't handle that kind of a load, then they're going to go into more failure and they're going to die. Now, regardless of the amount of stretch that's there, I can also increase the contractility by changing a couple things. The first is going to be my sympathetic nervous system. Remember, sympathetic speeds things up, causes the heart to contract stronger. Parasympathetic slows things down. Anybody know or want to venture a guess as to how the parasympathetic, by the way, could slow a heart rate down? What it might do?
This is a neurotransmitter, right?
It does, but what does the neurotransmitter do? Pardon me? Say it again?
Inhibitory?
Right, but why? What do you think it does in that postsynaptic membrane? Hyperpolarizes. So it's going to hyperpolarize essentially by allowing more potassium to exit out. And that brings the cell membrane down to more of a negative value. Therefore, it's going to take a lot more for the process to go on. So our sympathetic nervous system is the opposite. It's going to speed things up. Now we're going to talk specifically though about the contractile cells. I'm not talking about the pacemaker cells. That has to do with rate, and we'll get there when we talk about rate. This has to do specifically with contractility. And what it does is it basically allows for more calcium to be released. The more calcium that's released, the more it binds to our actin and myosin filaments, and therefore we're going to have a stronger contraction. So these two things basically are going to increase that this increases our end-diastolic volume. This is going to increase our contractility, which means it decreases our end-systolic volume. Remember, whenever that end-diastolic goes up and that end-systolic goes down, that increases stroke volume. And if I increase stroke volume, I increase my cardiac output. Now, I'm also going to have, so by the way, I probably just should have used the term because it's the more correct term. Frank Starling is the law. The physiologic principle is called preload. Okay? So you're going to hear this a lot where we're going to increase a patient's preload. That's where we're going to give them more blood, we're going to give them more fluid, and that's going to cause the stretch. The opposite of preload is afterload. Okay? Now afterload, again, stop and think about this. I'm going to talk about the left ventricle. Okay? And again, it's exactly the same in the right ventricle. So in the left ventricle, if I'm down here and I'm going to try and jump out, and there's the valve right here. So remember what we talked about yesterday with the Wigger diagram. As soon as I get more pressure, I have more pressure to push through the semilunar valves in the aorta, correct? Okay, that's how the process works. There is going to be on the other side of that door, the other side of the valve, a pressure, a resistance. Okay? If I decrease that resistance, it means more blood is then going to be able to be shot out of the ventricle. Therefore, I'm going to have a lower end systolic volume. If I have a lower end systolic volume, it means my stroke volume went up. Okay? Let me give you another example of afterload. So if I was to close this door here, okay, and this is the valve, and I decided I wanted to open the door and let you guys out, and we're going to pretend this is fall term, when everybody else is letting their students out. So they would be on the other side of this door, correct? So I would have to do what to try and open the door to let you guys out? I'm going to have to push harder because they're on the other side of that door. I have to use so much energy to do that, not very many of you are going to get out. But if I said, it's 8:15, no one's out there. Why don't we go now? No one's out there, so it makes it very easy and most of you can get out. That's decreasing my afterload. But afterload in general is just the resistance that the ventricle has to overcome before blood is ejected out. So when you go back to the Wigger diagram, that's this part right here. If I decrease the amount of work that the ventricle has to do to push it out through here, then my end systolic volume would be lower, which means that difference is greater, so my stroke volume went up. Now this is one of those diagrams. You might want to flip it because this is basically showing you the way that this particular textbook always does, which is something happened, which is the stimulus up here, and then this is going to be the outcome. But this doesn't change anything about, and I'm going to finish on one side of this, I just want to show you the diagram. Cardiac output is made up of stroke volume and heart rate. What affects stroke volume? An increase in end diastolic volume, which is my preload, and a decrease in end systolic volume, which was my contractility and afterload. Decrease in my afterload. And that'll tell you what those do, and this will tell you the things that affect that. So again, all you have to do is just either redo it yourself or flip it so that you have cardiac output at the top. These are two things that make up it. These are the two things that contribute to that, and we'll talk about heart rate in just a second and go from there. Now, and I'll come back to that because we're going to talk about the heart rate component of it now. Because when we talk about cardiac output is equal to stroke volume times heart rate. Again, an equation you need to know. Not necessarily do the math, but to be able to understand how the physiology works. So, with my sympathetic nervous system, so remember we have our autonomic nervous system which plays a role in our regulation. So we go back to those centers that we talked about, and we have the parasympathetic, and again, so we have cardioacceleratory, cardioinhibitory. Cardioinhibitory is going to travel along the vagus nerve, and it's going to come down. Cardioacceleratory is still going to start up in the medulla, but it goes through a simple chain, so it's going to come down and innervate a little bit more of the heart than what the parasympathetic does. So it's going to be these two things that are essentially going to affect rate, and this is going to affect contractility. It's one of the reasons why parasympathetic doesn't really affect contractility per se. So with our sympathetic, again, we have our beta 1s and our beta 2s, our alpha 1s, alpha 2s, and alpha 3s. Those are our adrenergic receptors. And depending on who your instructor was, for the most part, we really deal with beta 1s, beta 2s, and alpha 1s. Alpha 2s tend to be more central nervous system. They're presynaptic. They tend to be inhibitory. And beta 3s, which I didn't mention, are more fat mobilization. So those are the things we don't generally play a lot with. It's usually our beta 1s, beta 2s, and alpha 1s. Now, for those of you who had me, anybody remember the nice trick to remember where the beta 1s are? How many hearts do you have? How many lungs do you have? 2. So for the most part, your beta 1s are going to be on your heart, and it's not the only place. We're going to see that you have beta 1s in your kidneys, you have beta 2s in different places. But beta 2s we generally are going to have in our lungs. So those of you who work pre-hospital, those of you who've ever given albuterol, it's a beta 2 agonist. It's going to help open up your breathing tubes. Okay? So beta 1 are the receptors we're going to be dealing with in the heart. Now, what this does, it allows for the pacemaker cells to depolarize quicker. If they depolarize quicker, then my rate can go up. But remember, I still have that absolute refractory period that we have to deal with. So the other thing that this allows is for quicker relaxation, because then I can depolarize quicker again. This allows the heart rate to go up. Why do I want the heart rate to go up? It needs to go up because you're nervous. It needs to go up because you're going for a run. It needs to go up because the dinosaur is chasing you. Okay? We need to deliver more to the tissues than what the tissue has. Now, going back to this diagram for a second, and what I talked about yesterday, when does the heart fill? During systole or diastole? Okay, and again, that should make sense. Use the sponge analogy. If I take a sponge and I squeeze it down, can it fill with water if I'm holding it under the faucet? No. It's the same with the heart. This is systole. I'm squeezing the heart down to pump blood in a forward direction. I can't fill that. So it fills during diastole. Okay? When my heart rate goes up, goes faster and faster and faster, diastole shortens. So these blue areas shorten. Well, if that's when I have my filling, it should make sense that if my heart rate goes faster, my filling time goes down. If my filling time goes down, what do you suppose happens to my stroke volume? It goes down. This is one of the reasons why when you go running, you definitely increase your rate. Part of it is because we have a decrease in our stroke volume as our heart rate goes up. It's one of those nasty little things. Now, for most of us, it's not that big of a deal because the increase in the heart rate compensates for the decrease in the stroke volume. But if I have a patient, the ones that I showed you yesterday that were being cardioverted, remember cardioversion is what we do to live people, defibrillation is what we do to dead people. Those individuals were not doing well because their heart rate was going so fast that it didn't have time to fill, so their blood pressure starting to go down. Okay, so I answered a question yesterday about a rhythm that these people were called atrial fibrillation, which is the most common arrhythmia in the world. Okay, so again, if you were to look at their atria, it just looks like a bag of worms. Now that's different than ventricular fibrillation. Because remember, what are the two big pumps in the heart? The ventricles. So it's not ideal that my atria are doing this, but you're not going to die from it unless the heart rate goes so high. And when the heart rate gets too high, then your blood pressure starts to go down. That's when you want to treat it. So not everybody with atrial fibrillation is somebody that we're actually going to apply electricity to. Okay? Any questions on that? Yes, sir.
Is there a point at which, I think I've heard this before, where like when you're exercising and your heart rate gets too high, that it's like not, it would be advantageous to slow down and like make it a bit lower?
Oh yeah. So for most people, and I talked about this, I think in NP1. So you've got this kind of arbitrary number. It's called your heart rate max. And to calculate it, it's generally 220 minus your age. Which means you really shouldn't be playing around in that level for too long. Okay? So if you're somebody who goes running, I mean, let's make the math easy. Let's just say we're talking about a 20-year-old. So their max heart rate is 200. Now there's a thing called interval training where people will increase their heart rate to a certain point for a certain short period of time and then lower themselves back down, and then they run for a certain period of time or swim or whatever their event is, and then they bring it back up. But you don't play around in this area very long for exactly that reason.
Because it's less efficient.
It's less efficient. You're not getting your filling time. This is also the reason why, for those of you who take care of patients, we generally don't like to see patients anywhere near this. I mean, if I have a patient that has a heart rate of 150, unless they're an infant, we're a little concerned. We're trying to figure out what's going on. Because most of our patients aren't out running. Now, if I saw you on the treadmill and I had you on a Holter monitor, and you were at 150, I don't care. I would be a little concerned if you were, 60 years old, 70 years old, unless you were an elite athlete at that age. But, so when you start to look at heart rates, and we'll talk about kind of heart rate ranges as I proceed through the lecture, but that's the reason for the process. At this particular point, you're decreasing that filling time. And you're not going to be able to get more bang for your buck out of it. Okay? Now our parasympathetic, again, it allows for more potassium to leave, so we hyperpolarize the cell. When we hyperpolarize the cell, it slows the heart rate down. And as I stated before, as we sit here, our parasympathetic nervous system trumps our sympathetic nervous system when it comes to the heart. It's what's keeping your heart rate low. Okay? So they've done studies that if you were somebody who exercised on a regular basis, and let's say your heart rate was about 50, 55, your resting heart rate, and you're going to go running. So if I was to put a heart rate monitor on you, say an hour before this whole process started, okay? As you started to put on your running clothes, put on your running shoes, you're going to actually see your heart rate start to go up. Because what's going to happen is your parasympathetic nervous system is going to say, it's going to do that thing where we go outside and we run for a while, not looking for a Pokemon where you're actually running and paying attention to what you're doing. Saw like a group of people on Willamette the other night when I left the gym. It's like they were just there looking for a Pokemon. Dang. It's a little frightening. At least they were not in the road. So the vagus nerve pulls that away because it knows that you're going to have your heart rate up at 130, 140, 150 when you go running. So it removes the parasympathetic, and when we remove the parasympathetic, the heart rate goes up into the low 90s or the 100. Doesn't go above, because our sympathetic hasn't started yet. All we're doing, keep in mind, is that parasympathetic slows the heart rate down. It's kind of pushing it down. All I'm doing is taking the parasympathetic away, and the heart rate goes up. It's a natural preparation. Again, it doesn't happen just because you're exercising, but if you're somebody who exercises on a regular basis, then your body is starting to prepare for that. And then as you go running, the neurotransmitters, the hormones, epinephrine and norepinephrine, are being released, and that's going to jack your heart rate up farther into the 140s, depending on what you're trying to do. Now, there is another thing that affects heart rate. This is one of the reasons why sometimes it's hard to say that people have a perfectly regular rhythm. We write it sometimes, regular rhythm and rate, so you'll see RRR sometimes in a H&P or in the progress notes by the physician. It's called the atrial reflex or the Bainbridge reflex. So as more blood comes back to the right atrium, it can happen in the left atrium, but the right atrium tends to be the one that has the greater amount of baroreceptors. So these are cells that sense pressure. When they push down, if there's too much, then it increases the heart rate because they don't want the blood to back up. So you have this temporary, got to increase the heart rate, and then it's like milliseconds, it goes up, and then we push that blood forward and the pressure goes down and it slows down. So when you watch somebody, and you can see this when they take really deep breaths, and again, you'd want to do it on healthy people because people with asthma, chronic obstructive pulmonary disease, they respond differently. So here with the Bainbridge reflex, when you take a breath in, okay, what happens is that creates a negative pressure in my chest. That negative pressure gets transmitted to my blood vessels. So the one thing that I'm going to talk about in the vascular chapter is that blood pressure moves from high to low. So if I grow and create a negative pressure that's transmitted to my blood vessels in my chest, that creates a negative pressure, correct? Which is like a straw. It'd be like somebody putting a straw inside someone's chest and sucking it up so the blood actually kind of gets pulled up into the lungs or into the heart. That's what's happening with the Bainbridge reflex when you take a breath in. So more blood comes back. Uh-oh, too much blood. We're going to have a temporary increase in it. That's the reason when you watch somebody breathe and you put them on a heart rate monitor, you will not always see this exact, perfect, regular rhythm. It's not irregular, but there's enough variability that you go, that doesn't look right. And it's because of the Bainbridge reflex. And the Bainbridge reflex, one of its primary influences is your breathing pattern. Now, this is, I put this in here because it is in your textbook, and it's going to kind of walk you through a little bit of this component here. Okay? So, this is that G protein that I keep talking about. G protein throughout the whole entire body. We'll spend a lot of time with them in the endocrine system in chapter, or in AP3. But here is a hormone. Also could be a neurotransmitter, just depends on what's releasing it. So norepinephrine is one that, depending if it's coming from a nerve, it's a neurotransmitter. If it's coming from the adrenal medullas, it's a hormone. So here I bind, we activate, we have our cyclic AMP, we have our kinase, and this is not something you're going to have to reproduce. Showing you what it does. So what this does is these kinases over here are going to cause more calcium to be released from the sarcoplasmic reticulum, but it also allows for more calcium to come in from the extracellular fluid. Okay, so this would be a way that you have both an increase in heart rate, if I'm talking about a pacemaker cell, or an increase in contraction, if I'm talking about a contractile cell. Okay? So more calcium out here will allow for stronger contraction. If we're talking about this one over here, more calcium coming in is going to allow for that quicker depolarization. And again, I'm going to keep coming back to this so that everybody kind of starts putting it in their little noggins. Contractile action potential. That too is caused by a slow calcium channel. In other words, it opens slower. This is our pacemaker cell. This is the fast calcium channel. This is what dictates the heart rate. Strength to contraction, heart rate. So when we look at this diagram here again, cardiac output, stroke volume, heart rate, increase sympathetic and decrease in parasympathetic. These are all things that would increase. You have to memorize the opposite? No, because if an increase in sympathetic nervous system causes my heart rate to go up, obviously a decrease in the sympathetic nervous system will cause my heart rate to go down. Okay? A decrease in my parasympathetic. So again, I'm going to go running. I want my heart rate to be able to get up to about 140. So here, I want to decrease that parasympathetic activity. Heart rate comes up to about 90. You go running. These bloodborne hormones start circulating around, increase my sympathetic, and that's going to cause an increase in heart rate and increase in cardiac output. Again, probably the biggest, these next two chapters, this one and vascular, are the ones that present the most physiology that you guys have been exposed to so far. And sometimes physiology is not everybody's best friend. So we're going to keep talking about this regulation of heart rate. What are some of the other things that can that are components to it? So you're going to see this term a lot, catecholamines. Catecholamines are chemicals that have what's referred to as a catechol. In other words, the same basic backbone. So epinephrine is a catecholamine. Norepinephrine is a catecholamine. This is one of the reasons why people who have asthma and they are Olympians are not allowed to take albuterol, because albuterol is a catecholamine. In other words, it can speed things up. That would be considered an ergonomic aid. In other words, something that facilitates or aids in that athlete's ability to perform. So they are not allowed to take albuterol if you are an Olympian. Okay? Even if you have asthma, you got to figure out something else to do. Thyroxine. Thyroxine is your thyroid hormone. Okay? The thyroid hormone, again, we'll talk to a great degree about in the ANP3 in the endocrine system, is the powerhouse of the body. So when people are taking too much thyroxine, or if they're producing too much thyroid hormone, they run hot. Their temperature is up. They have a lot of energy. It's like basically endogenous crack. Not good for you. Okay? But that increases it. When it comes to this part, I want you to know that the ions will affect it. I don't need you to know the specifics. So just know that ions affect your heart rate. We're going to spend more time on this in fluid and electrolyte and ANP3. But obviously, if I have sodium is going to cause a quicker depolarization. If I have an increased amount of calcium on the outside with cardiac cells, it depends on which cells we're talking about, because there is some relationship between the level of calcium and sodium channels. So that's why you don't really need to get in the nitty-gritty of this. I just want you to know that our ions are electrolytes, things that when you put them in solution, they carry a charge. It's the term, that's how you have an electrolyte. They can affect my heart rate. Now, some of the other factors. Age. If I'm taking care of a patient and they have, again, a heart rate of 140, 150, I might or might not be upset. It depends on the age. If I'm going to a delivery of a child, it's not uncommon for them to have a high heart rate. If I'm taking care of grandma who's 150, well, she probably wouldn't be 150, but her heart rate might be. Let's say she's 80 and she's laying in bed and her heart rate's 150, that's bad. So the heart rate decreases as you get older. So as you go from infant, newborn, up to an adult, now there is a point that stops. It doesn't mean that when you get to be 104 years old, your heart rate is 3. Okay? There is a point at which you no longer have a decrease in your heart rate. But age is a very, very big factor. And that's something that you always want to take into account, again, when you're taking care of your patient population. Because even if I had a kid who was 8, if their heart rate's 120 and they're laying in bed, I'm going to be concerned. Why? Because they're not doing anything for their heart rate to be 120. Do you have a question?
Yeah, why does it get lower / why are babies' heart rates so high?
Has to do with the tone, parasympathetic tone. It becomes increasing as the person gets older. But again, it's not one that, I mean, we use it, so if any of you ever go to deliveries, we use the heart rate as a gauge for how well they're doing, and the number that we generally pick is 100. Anytime the kid's heart rate's less than 100, we're trying to intervene or do something. And again, unless the kid's pink, warm, and dry. So the one thing I also try and shove up everybody's behind so that whenever they get to their professional programs, they get it is we treat the patient, not the monitor. Okay? I've seen people a lot where they see the one rhythm I didn't show you yesterday on the monitor or on the thing was asystole. Flatline. No cardiac activity ever. Dead. I've seen that on the monitor and the patient, someone's talking to the patient and they want to do CPR on the patient. That's what I mean by treating the patient, not the monitor. Okay, the monitor is an electrical piece of equipment. Lots of things can go wrong with it. But if your patient's talking to you and it shows that you have a blood pressure of, you can't even palpate, or not, I shouldn't say palpate, because if you couldn't palpate, it wouldn't be there, but let's say you put the Dynamap on and it was automatic and it said the blood pressure was 30, but they're having a conversation with you, something's wrong with the blood pressure cuff. Okay? So, again, you always want to make sure that you're treating the patient and not the monitor, and that can happen with various things when people get excited. Exercise, obviously, it's going to go up. Okay? So the more you exercise, the higher it goes, and that's that 220 minus your age. You can exercise yourself. Probably not to death, because you have what's referred to as psychological volition. So one of the ways that we used to test people is what's referred to as a VO2 max. We want to see how high we can take their, to test their cardiovascular endurance. So you might take a cyclist, you might take a runner, and we're monitoring them with an EKG. We have a device in their mouth where we're looking at the amount of oxygen they're bringing in, the amount of carbon dioxide that they're blowing out. And we try and see what's the highest that I can get them to run. The problem is that most people stop because they just can't do it anymore. Not because their body can't do it, it's because their brain says, I just can't do it. So that's a psychological volition. So it's hard to get somebody to exercise the piss out of them where they're basically going to collapse, physiologically. Some people you can do it, some people you can't. Temperature. The colder you are, the lower your body temperature goes, or the lower your heart rate goes. So sometimes you might see grandma who fell on Friday, she lives by herself. No one found her until Monday morning. She's on the ground. She might be diabetic. She might be very, very cold. It's very, very common for her to have an extremely low heart rate. Okay? And that's not necessarily a good thing, by the way, especially with the cold. So it is good when you can find a patient who's cold because it protects their brain, but we're talking about flash freezing. We're not talking about grandma who's laid on the floor for two days and her body temperature went down. We're talking about somebody who falls in ice cold rivers, avalanche, those types of things. That's a flash freeze, where when they're cold, it's a good thing because if their brain isn't functioning, their heart's not going round and round, that coolness protects the brain. Okay, so don't get excited when you're taking care of grandma and it's like, oh, she's cold. Yeah, but she's cold because she's been laying there for 2 days. Okay, so, and then obviously, we all know this probably from yesterday, probably today, tomorrow. It's going to be 95 degrees, I think, on Friday. When it gets hotter, our heart rate goes up. We're pumping more blood around. We're trying to cool the body down. We're vasodilating. So last couple things for this chapter, and then we'll take a break, and then I'll go into the vascular chapter, are some terms I want you to know. Okay? So the first term is bradycardia. Okay? This has a very specific definition. So I want to make sure everybody who's here is very clear on it. Bradycardia does not mean a slow heart rate. When you translate it, brady means slow, cardia means heart, so it's slow heart. The definition of a bradycardia is a heart rate less than 60. Now, some people are naturally bradycardic. So when you come into the emergency department, again, if we had Lance Armstrong and he came in and his heart rate was 41, we would describe him as being bradycardic. If I put him on a monitor and saw that every one of his P waves were exactly the same, then I would say he's in a sinus bradycardia. But bradycardia has a definition of a heart rate less than 60. It doesn't mean it's bad. It's just a description of the heart rate. There's probably a lot of people in this class who normally are bradycardic. And again, hopefully sinus bradycardia. So if you have one of those blocks that I talked about yesterday when I showed the arrhythmias, then that's not a good thing. Now the opposite of that is tachycardia. Tachy means fast, cardia means heart, fast heart. That is not the definition. The definition of a tachycardia is a heart rate that is greater than 100. So if you're ever taking a cardiac exam, if you're ever in the paramedic program or you're in a nursing class, and the answer is identify which one of the following is tachycardic, if one of them does not have a heart rate greater than 100, it cannot be called tachycardic. In fact, there are names that change. This is not something you're going to have to know, but there is a thing called multifocal atrial tachycardia. Okay? And it just means that there are varying places in the atria that are sending off impulses. They're just firing, not the fibrillation. Okay? These are firing, and there might be 3 of them. If the heart rate's less than 100, it's called a wandering pacemaker. I can't call it tachycardia. Why? It's less than 100. Okay? So use that number to be able to figure out some of your answers. The next bullet up there is a term that's misused quite frequently, not only in the lay public, but also in the medical community. So congestive heart failure, most people think of congestive heart failure as just being heart failure. Mom's got congestive heart failure. Congestive heart failure is a very specific term. It's the left ventricle that's failing. Now remember that these are pumps. And if one starts to fail, it's going to put increased work on the other pump, which means the other pump is going to have to work harder, and it'll eventually do what? Fail. So early on, it's not uncommon for somebody with congestive heart failure to just demonstrate signs and symptoms of left-sided failure. But if it goes on for too long of a period of time and it's not being treated, it will cause right-hearted failure because it's a circuit. Now, there is a name for right-hearted failure. Okay? Right-hearted failure is called cor pulmonale. That's specific to the right heart. We see this with lung disease. Because again, this is my right ventricle. It's pumping blood to the lungs. If I have problems in the lungs, that means this right ventricle is going to have to work harder. If it has to work harder, it's going to get bigger. And if it's not treated, it will eventually fail. And again, because then stuff will back up into the body, it's going to eventually put more work on the left ventricle. It's going to get bigger and it's going to fail. So this is the way you want to start thinking about your anatomy and the physiology so that you can put it into the disease process from that standpoint. Now, this last one, these last three, I just want to show you. You're not going to get tested on it, I don't believe. I'll have to take a look and see. Hearts don't get put together correctly. Okay? So I think that you have a section at the end that has to do with developmental, embryological development of the heart. The heart's one of the very funny organs that actually starts to change and rotate its position. And again, that's the reason why the apex, which is normally considered the top of something, is actually the base, or the end portion, and then the base is the posterior wall. So these are things that are common or that occur when the heart is forming during utero. So this is a very common process. It's called the VSD, a ventral septal defect. Usually when someone says that they had a hole in their heart when they were a kid, more than likely this is what they're referring to, because this is the one that causes the problem. Having the ASD, the atrial septal defect, the PFO, stay open, or having another hole, in and of itself is not a horrible thing. We're probably going to want to keep an eye on it and potentially fix it. VSDs need to be repaired. So a ventricular septal defect. In other words, there's a hole between the wall here. And you can see that it actually occurs more frequently than most people would imagine. 1 out of every 500 births have it. And again, the problem with this is going to come, which is the stronger ventricle. Because if my right ventricle is stronger, then I'm going to have what's referred to as a right to left shunt. So I'm sending blood over to the left ventricle. This is bad, because this is generally deoxygenated blood, which means I'm adding deoxygenated blood to oxygenated blood. So what goes out to the rest of the body actually has a very low level of oxygen in it. And that's going to be detrimental. These are kids that have kind of a blue tinge to them, a cyanotic heart disease type of a kid. Now, if the left ventricle is strongest, which it usually is, then blood gets shunted over this way and it's a left to right shunt. Well, not really too bad, because that blood's just going to go to the lungs, pick it up, so you're just going to have a little extra oxygen. The problem is that if I put too much blood over here, then this can go into failure. I can put too much fluid in my pulmonary capillaries and have problems with my lung. It starts to get a little bit more bizarre as you start to move through the cardiac anomalies. By the way, there is a book just on cardiac anomalies of the newborn. That's how bad the heart can get screwed up. They're usually associated with other anomalies. So when you deliver a kid and you notice that they might look like they have Down syndrome and you didn't know it, or they have strange set ears and it wasn't picked up, then we would start working you up for possible cardiac anomalies, because a lot of the anomalies go hand in hand. So this is called coarctation of the aorta. And in this one, you have a narrowing in the aorta itself. And it can happen actually along this whole pathway. There are areas where it tends to be a little bit more like this, but it can happen along that whole component here. Doesn't occur as often as the VSD, so 1 in 1,500. We usually diagnose this because we do blood pressures on all the limbs, and specifically when we notice that there's a drop in the blood pressure in the legs as opposed to the arms. Why? Because we've got a big narrowing right there. So if I'm doing a blood pressure, what's that? Anybody remember what vessel that is? The brachiocephalic artery. What comes off the brachiocephalic artery? Right subclavian, then goes right axillary, right brachial. So if I was doing a blood pressure over here on my right arm, it might be totally normal, and I would never pick up the fact that the kid has a core. If on this one, would there be a change in blood pressure in my left arm? Why? Comes after what?
Comes after the
Left subclavian. Already.
That wouldn't add to the blood pressure in those arms
No.
because of the restricted flow?
Potentially, but we don't generally see it enough to go, oh, but we should probably check other things. It's one of the reasons why we do a 4-point. So since anything obviously below that in the descending aorta is going to go to the legs, we notice a decrease in blood pressure. Now, not the most screwed up, but probably one of the highest of the screw-ups is a thing called tetralogy of Fallot. Tetra, so there's 4 defects here. Okay, it's called TOF. And these are the 4 defects that occur. And again, it's fairly uncommon, but still it occurs, 1 in 2,000 births. So what you see is we're going to have that pulmonary trunk is what's referred to as stenosed. Remember, stenosis is a narrowing. So that means it's going to increase the amount of work for that right ventricle. We have a hypertrophied right ventricle, which means the wall here is actually thicker. Why? Because it's had to pump against that. That's an increased work. It's a resistance. Remember we talked about afterload? This would increase the afterload, not decrease it. We have that VSD, so the ventricular septal defect, right here. And then probably the most strangest thing of them, the aorta, which normally comes off the left ventricle, comes off of both. This is one of these things that you hope is identified by the pediatrician, depending on where you're at, and then hopefully they call a hospital that has a neonatal intensive care unit, specifically one that has pediatric cardiovascular surgery. So if I was to pick this kid up here in Eugene or in Coos Bay or Roseburg, this kid would go to our hospital, and then this would be diagnosed and they'd go to OHSU or Mayo, because they're the only hospitals in town or in the state that do pediatric cardiovascular surgery. This is a multi-step repair. Like, we're talking years. These kids have what's referred to as a TET spell. So when things change, when the hemodynamics change and it switches, so blood is now going to be going this way. So the kid gets very hypoxic. They learn this automatically. It's very strange. But if you were to watch these kids before these repairs got done, they would just go into a crouching position. And that crouching position changes the pressures inside their lungs, which changes the hemodynamics, and it reverses the blood flow. So it's called a TET spell. So before they learn how to do that, we usually take care of it because we see it occurring and we give them morphine, try and calm them down, that type of thing. But they just kind of go into this little crouching position and they change their hemodynamics on their own. So if you like cardiac stuff and you like the challenge of cardiac stuff, so you can do the adult stuff all day long with, where we're going to have the, the arrhythmias, you're going to have valve replacement, you're going to have cabbages, so the revascularization of the heart. When you get into the neonatal intensive care unit, you get to deal with all of this, which is just how the heart just got so screwed up in its process and how they're going to fix it. So it's kind of impressive from that standpoint. Any questions? And again, that whole thing not going to show up on your exam. I'll try and make sure that there isn't. I just want to show you how things can go wrong. So make sure you have your vascular notes. Again, this is not the blood vessels. You're looking for the vascular chapter. It actually might say blood vessels. So